Good afternoon, everyone.
Don't say anything bad.
It's amazing to me because I think it's most appropriate that we're addressing preventive health care and the very important work that Dr. Rimmer and also Kathy Bodine, Dr. Bodine are doing. But to address preventive health care issues in the context of today's launch of the Declaration of Rights, because access to comprehensive integrated health care is a key gateway to quality of life for people with intellectual and developmental disabilities. So it really is a nice marriage that we have between the two today. I also want to thank Dr. Rimmer, who joined the ANCOR group at our spring conference this year and actually did a presentation on nutrition and exercise and his pyramid of healthcare, which is wonderful, to our direct support professionals who were in attendance. That's another key important stakeholder group moving forward as we address preventive healthcare issues. So we're here today to respond and also present some other viewpoints on the issue of the epidemic of obesity within the intellectual and developmental disability population. I'm going to talk in a little while about some things that ANCOR's doing, but let's start off by hearing from David O'Hara, who is Chief Operating Officer at Westchester Institute for Human Development. I'm going to mention him later as well on his reactive commentary.
I want to start by just picking up on Jim's presentation. I've known him a long time, and he always blows me away with how much information and how many ideas he manages to pack in the shortest amount of time. And you've overdone yourself today, Jim. You've given us so much to think about. It's unbelievable. But I want to tie something that Bill Coleman said to what Jim just presented together for us. And that is, where do we find the money to develop the quality of lifestyles that we'd like the Susannas of the world to have? And there are some health and social expenditure data from the Organization for Economic and Community Development that really point the way and point to the US as the outlier in terms of how we allocate health and social expenditures to allow for the quality of lives we want people with cognitive disabilities to achieve. When you look at the relationship between health expenditures and indicators of population health over time, particularly life expectancy and obesity, here you are with the United States spending more per capita on health than any of the other 34 countries in that group, and achieving 34th ranking status in obesity as a population indicator. At the same time, when you look at life expectancy at birth for people with cognitive disabilities, in the US, we don't have data that tell us that, but in Australia and Europe, and in England in particular, we now have studies that not only do we have very shorter lives, but they're significantly shorter lives. People with cognitive disabilities are living 10 to 15 years, fewer years of life than the average population. Jim talked about chronic diseases and the way that they relate to this picture that he's going to develop through his longitudinal study. What he didn't say is that when you look at the prevalence of chronic health conditions in people with cognitive disabilities versus the general population, you're looking at ratios of difference that are sometimes 6 times higher in people with cognitive disabilities for diabetes than they are for the general population. One of the things that Jim's study is going to help us understand is, why is that? Because at the present time, we just don't know why there are these major reduced life expectancies and why there are these major increases in chronic health among people with cognitive disabilities. The other thing that we do know, though, in terms of expenditures, when you look at countries that are doing much better in achieving good population health, the balance of their expenditures on healthcare versus social services and supports, employment, housing, other kinds of things. For every dollar that they spend on health, they spend an average of $2 on other services and supports. In the United States, for every dollar we spend on health, we spend 55 cents on other services and supports. That's where the money that Bill wants to create quality lifestyles can come from when we chart to change that balance. That's it.
By the way, I forgot to mention that we are going to have time to take questions from the audience as well, so be thinking about your questions. I know both, certainly the ARC and ANCOR are both made commitments to preventive health care as a priority within their organizations, and to enlighten us on what the ARC is doing is my good friend, Ann Cameron Williams.
Hi, everybody. Delighted to be here as one of the representatives from the ARC of the United States. You know, I've seen Jim present before. I've seen him run vigorously back and forth at UIC from his office to the elevator on some important task while he was gathering some of these data years ago. And I'm also overwhelmed by the depth of the data that he's presenting. As a representative of the National Association, over about 700 chapters of the ARC in all of the United States, all states in the U.S., I'm reminded that data is critically important. So my response to Jim's data is it's about time. The word relentless comes to mind. In that people with intellectual disabilities and perhaps cognitive disabilities outside of what the ARC focuses on, in many ways are just refusing to be ignored. This is no doubt attributed to self-determination and self-advocacy in the civil rights movement that's carried by many of the organizations that are represented here and people that we know. It's represented by families uniting against injustice, a movement that began in the 1950s in the United States, which ultimately became the ARC, and we're still run by families at the top of all of our independent 501c3 organizations. It's relentless because people with intellectual disabilities refuse to be ignored in arenas such as now health and health promotion, health awareness. And I want to call out the University of Minnesota has an amazing project called selfadvocacyonline.org, which helps train people with intellectual disability at a linguistically appropriate level for people that might have low reading skills. And I mention them because in the context of what the ARC is doing relating to health and health promotion is last year we were very fortunate to receive more or less a $3 million 3-year commitment from the CDC to run a health promotion initiative called Health Meet. And together with a tiny little organization called Special Olympics International, we together are approaching this problem in our ways. And so we have national efforts to train people with intellectual disabilities, their families, medical professionals, and health students. We have engaged many of the partners in the disability community to do this, and we're also running actual health screenings or assessments in 5 different states. We're collecting the data through HIPAA-compliant health, electronic health records that are cloud-based, very progressive for our field, through Therap, actually LLC, who is here today. But, you know, I think the key to all of this is, Jim, you need to keep doing what you're doing. And David, you need to keep doing what you're doing. But the bottom line is if we don't get families, parents, staff people that are caregivers, and people with intellectual disabilities to change their behavior and actually start using some of this data. I mean, you know, I'd love to have a Skype guy tell me every morning, hey, it's time to get up and do those, you know, steps. You know, that, I mean, that works for all of us. But until we can really convince the families, educate the families, and educate our staff people to start adopting these technologies, we are hopelessly not going to see a lot of change. I think one of the things that the ARC is also committed to contributing to is to educating staff that are running residential programs or working in residential programs to choose healthy foods. You know, and it seems like such a minor thing, but if you're going to go to a food place that's very cheap but is very low on the high nutrient, you could get more McDonald's than you can broccoli for the same amount of money. So I think there's a lot of factors surrounding this health promotion and the outcomes that we can do it, and it's a hard fight. So
I just want to piggyback on Ann's comment about residential programs. That is where the rubber hits the road, both around staff, people served, and family. One of the things ANCOR has done is we've submitted a grant proposal to CMS's Center on Innovation, and that whole grant proposal is around attacking this problem in group homes around the country, starting with this pilot program that we hope will be funded. We have assembled some wonderful partners in addition to our participating provider organizations, including Northwestern University, AADMD, and that's the group that really does work on curriculum development and training of the healthcare and dental providers, Mainstay, and David O'Hara as well. Looking at a online, user-friendly, but data, evidence-based driven attempt to attack the obesity issue within this population in an educative yet way that we think people will readily accept, and important component of that, educating the direct support staff. So we're very excited about that, and the need for the data collection is just imperative. And getting back to the dollars and cents piece also that David mentioned, just in our own work that we did in putting this grant proposal together, the cost savings within the healthcare arena around fewer medications, fewer emergency room visits, reduction in chronic conditions among this population is enormous, with the idea that that money can then be pumped back into the system to fund many of the things we've talked about today around technology, and also a well-compensated and well-trained direct support workforce. So we're very excited about that. Additional comments before we go to questions? David?
Just one other thing I want to touch on in terms of how we're going to generate the information that will allow us to take advantage of what Jim is learning through his longitudinal study. There are two things going on right now that can really help us create the health environment that will be cost-effective and efficient in terms of dealing with what is a highly complex, not very well managed picture right now, and that is the fact that when people have multiple comorbid chronic health problems, everything falls apart. We do not have good models of healthcare provision to cope with those kinds of individuals, and that's exactly the population that you were describing. The center that I work for, one of the things that we've taken on as our major role in the world is to be a comprehensive health resource to about 7,000 people who exactly fit the description that Jim described. And when you just think of medication management, as you all know in this environment, for those kinds of issues, that is fraught with difficulty. So in the way that healthcare in the United States is changing, and in a very positive way, there are two things that I think are going to be powerful drivers of how we use the knowledge that we acquire about who these people are, what they're experiencing, and what do we need to do. The health information technology will help us make that work effectively. One of the first things that we have going for us in the United States that I don't know of in quite the same way in any other country is this whole concept of a patient-centered medical home. When you look at what changes health differences, health disparities between racial and ethnic minorities, you find that when people across racial and ethnic groups can say, I have a medical home and my doctor's name is, that maternal mortality goes down, infant mortality goes down. You can reduce health disparities that persisted for years when you put people in a supportive health environment. We have to find a way to create the equivalent of that for people with cognitive disabilities. And that's something that we're working on, using the kinds of technologies, smart technologies, that can allow us to put interactive tools into the lives of people with cognitive disabilities so that they can talk to their healthcare team in a different way and have a real experience. The other thing that's critical, and I think Jim mentioned it, we have got to create voices for consumers to tell us what they're experiencing, how well it's meeting their needs, and what they would like to see change. And so the other thing that we're working on has been the modification of existing national surveys supported by the feds that try to get at aspects of that. And the one we've taken on most recently is the survey that goes with, does this person feel they have a medical home? It's a CAP survey. We've modified that. We did a research project. We took that survey, we changed the language, we put it on an iPad, and then we tried it out with folks coming to us for comprehensive health care. And 90 people over the course of 2 weeks were able to complete that adapted survey, only 3 with some support. The rest could do it independently on using the iPad technology. And that's one dimension. The other was the look on their faces when they were given the opportunity to talk about what they liked about their doctor, what they liked and disliked about our clinic, and those kinds of things was incredibly powerful. That's the other dimension that I think Jim hinted at, that we have to make sure we build in to any of these technology advances, that we always create voices for the individuals we're working with as part of the evolution.
That's a wonderful example of technology at work.
Yeah.
Questions from the audience? I think we now do have microphones in the aisle.
Hello to my friends. Something I've thought about over the years is, and part of this living an international lifestyle, is how do you change culture? So what I'd like your ideas on and your thoughts about how you change culture, whether it be New York City in the neighborhoods, whether it be Chicago in the neighborhoods and so forth. And so I give the example of being in graduate school with a number of oncologists taking a statistics course taught by a guy at CDC on the faculty at Emory University. And we analyzed the largest existing data set on smoking and cancer that was available at that time. And at the end of this, everybody in the room stopped smoking. I used to smoke a pipe, and think of university professors way back when. Then we took that data and showed it to the Emory University medical students in an epidemiological class. 95% of them stopped smoking in a year. But if you think about the power of that, and you're teaching to the converted, and that is scientists, probability, and so forth, how do you, and so I'm going back to Bill Coleman and a number of things that have been said, which I think are just absolutely marvelous, that's where we're headed and so forth. The other side of me is very interested in culture and how you change it. One side of me says, you got a culture, you can't change it. The other side of me says, well, you can't change it, but you can create a new culture. And so when I notice in different parts of the world where I am, that the people who are healthy, but they behave differently. But there's some fundamentals. And so what I don't have all the answers, but it's something I've been thinking about for a long time. How do you, in your thinking, here in the United States, in a very constrained world, think about changing the culture, particularly when you not only have the culture, but what you also have is a way of relating to each other. So this is Nick Christakis' work on connectedness, tying in IT, neurophysiology, and social sciences. And what's really powerful is the culture is very powerful, and the social network you have is very powerful. And if you don't have those fitting, you don't change. So what are your thoughts about that?
Well, Dr. Albrecht, let me see if I can answer at least a little bit of that question. I'm going to put on my hat as a mother right now. I have a 19-year-old young man with Down syndrome. And I know, especially spending most of his youth as a single mother, I know what I went through in terms of trying to juggle school and trying to juggle a job, or 2 or 3 jobs actually, and forget housework. And it was lucky if I had peanut butter in the house on some days. So, I think going back to really understanding the target audience and understanding the challenges, the joys, the barriers they face, whatever solutions we come up with, we have to package it within a consumer-friendly, toolkit, market, the whole package, so that it can be inserted into their life as seamlessly as possible for use. That would be one aspect. So there's many facets to this. I mentioned before, there's several other pieces of health promotion that the ARC is aware of and we're trying to work on. We're trying to present this as a social movement. It's cool to be healthy. We have our new National Council of Self-Advocates that are people that identify as having ID within our system. They may also be part of other national groups or local state groups, but this is a place for them to help contribute to the shaping and the operations of the ARC. And so they're involved with, we're really using the target audience to be the message bearers so that they can do peer-to-peer discussions and get people involved. Hey, why don't you choose celery instead of French fry? And we're hearing these anecdotal stories through Health Meet of amazing change. A group home that developed their own walking club, and after the walking club, they go to the local, deli, 7-Eleven kind of place, where the guy always had cookies and candy and soft drinks and everything. And they took what they learned from Health Meet, and they went to the owner and they said, you know what? This is really junk, and we have a right to be healthy. And so we want bananas, and so he changed his buying habits, and that's what they do now. Incremental change, massive impact. If we can replicate that 5 million times, 5 times a day, we have it solved. So that's would be my.
Yeah, I like that. I'd like to build on what Ann said. I think. Well, let me mention 2 things. One, Bill Coleman mentioned inflection point. I use a term called tipping point. There was a book written by Malcolm Gladwell called The Tipping Point, that we all have our responsibilities and roles for the greater good of the community. And in the tipping point, you'll notice that there are people who would be willing to pick up an adult. If they got a tweet on the way to the gym and there was somebody in that community that needed a ride, they would pick them up. I'm guaranteeing it. If you can convince the community that as a whole, the family unit is the adult with the intellectual disability. This is part of your community, and you have a right and responsibility to them no different than any other family member. You can get that to work. And with technology today, Gary, this can happen instantaneously. You need a computer modeling center. You need to find those best practices, the one Ann described. These are all happening all over the country. David Braddock and I heard of a woman in California at the ANCOR meeting. She's got adults with very low BMI. She gets fresh produce. She brings it in. It's less costly than other items. But I think one way to do this is to have that, and maybe something for Bill and Claudia to think about, but to have a computer algorithmic adaptation modeling center where we can gather the data in one central command center, and then from there kind of identify where are the best practices and try to get those best practices then adapted to other communities. It all has to be about choice, right? So if that person wants to go to McDonald's, it's really trying to change the environment, not the person. Make that environment conducive for them to go to Whole Foods. Encourage them to eat healthy by altering the mapping of the context of their micro, meso, and macro environments. And I can almost guarantee you that you'll see a change in health babies, just like we saw years ago with smoking, when they started to less advertising showing the glamour of smoking, less people doing it. Now you got people huddled against buildings. It doesn't look that cool anymore. We've got small increments, but for the most part, smoking is not cool. So all of these elements have to then be brought and studied. And with big data and analysis through this modeling technique, we can start to study this more systematically. 30 years ago, we would talk about obesity, but we didn't have any tools to do anything about it. Today, we do.
I'm going to get to 2 more questions. I know this gentleman here has been waiting.
Thank you. So I wanted to address a couple of the comments and questions. In terms of how to incentivize people to eat healthier, I think if there was some kind of a debit card given to people who were at risk that would reduce the cost of purchasing certain items, like you can buy healthy items at McDonald's or healthier items. If there was a card that would reduce the cost of purchasing those items, that could be an incentive for people to purchase them, or some reduction on eating in healthier restaurants based on a card, like a food stamp type thing that was given to people who needed to eat a healthier diet. But in terms of the obesity issue in general and community, so we have a healthcare crisis, and the two major issues, I think, for the population as a whole are obesity and depression, both of which relate to a lack of community. So we at CU, we've started a project which we want to spread to the community in Boulder, and we're looking to partner with people elsewhere, called CU Walks. And it's a model for something that I'd like to call community walks, where there are regular walks at the same time every day on the same route in every community. So people can join knowing that at noon every day there's a walk and there's no cost, and it's led by volunteers. And I think that that's a way to build community and change culture by reconfiguring the environment and saying that there's a walk that comes down this street every day, just like there might be a bus, and you can join every day. So we've started this, and we're interested in developing some affiliation.
Good suggestions. I'm reminded of the Sibling Leadership Network, and I know the Ohio chapter has created chapter book clubs. This is to increase literacy among people with intellectual and developmental disability. There are now 600 clubs around the country. You could have walking clubs, you could have eating healthy clubs. I mean, the question about culture, it's true, it's incremental, but those are good examples of how that might happen. Ari, you have the last question. I wish we had more time, but.
All right, last question, a lot of pressure. So I think all of you made a very compelling argument for something that we were already generally aware of, but it's good to reinforce that obesity and poor lifestyle choices represent a significant challenge for the cognitive disability and broader IDD community. And there's a lot that can be done around that. I'm particularly interested in seeing what can be done as we start to shift technology development from being provider-centric to being centric on people with disabilities. But I do want to raise one somewhat challenging ethical question that comes up as we enter into this space, talking about obesity and poor lifestyle choices, which is namely, how do we put together constructive and meaningful and effective strategies to address this problem without adversely impacting the progress that we've made on instilling that idea of dignity of risk within our service provision system? And it's clear to me that the people who are speaking, understand that that is something that needs to be considered. But when you think about the average environment inside of a group home, or even the average environment inside of a family home, it seems to me that that is not something that there is a level of awareness that we need to be facilitating greater access to options, but not closing off options, even if we disagree with them or they may have some type of negative health outcome. So I guess my question is, how do you perceive the field can move forward simultaneously on health promotion and on dignity of risk without compromising the latter?
That's a great question, Ari. And it's something that has been brought up time and time again, so we're used to hearing this question. We believe that education is the quickest way and the most ethical way to helping people with cognitive, I'm going to say intellectual disabilities, because that's who the ARC represents, is to educate them about the risks associated with poor lifestyle choices. At the end of the day, They, of course, have, they should have their right to decide. And there's always that balance of, you know, if somebody wants to step off the 12th floor into air, do we let them do that because it's their choice? So there's that ethical question that comes into play, and I think everybody wants people to really have not feel like they're locked away. People with Willie-Prater syndrome, I'm sure you're aware, have very difficult issues with controlling their food impulses, and so there's food that actually has to be locked away. If you didn't lock it away, they would literally eat until their stomach explodes. So we try to go education, a little bit of peer pressure in terms of, hey, you know, don't eat those you don't need all of those French fries. You can eat 5 of them and still get what you want. But from a more of a systemic approach, helping families understand that, sure, I mean, I'm guilty of it. Jeffrey loves grilled cheese. That's Grilled Cheese United is his email. And, you know, there's been times when I've been too busy to fix the chicken and the, you know, all of the things that Rimmer eats every day. And so, but I have to, as the family unit, I have to be responsible enough when I'm at the grocery store not to grab 2 things of the American cheese slices and maybe ease up on the mozzarella string cheese and the cheese pizza, and, you know. So, I mean, I think it's a balance of educating, but then also kind of limiting some or increasing healthier food options. Right. I think is in terms of healthy food.
I think that was an excellent question, Ari, and one that's deserving of continued dialogue. So I think each of us should think of how we might extend that dialogue within our own networks moving forward. I'd be remiss if I didn't thank our panel and just the excellent presentation by Jim Rimmer. So thanks to all.